The adrenal glands are essential organs of the endocrine system. They play a significant role in the maintenance and balance of water, sodium, and potassium. They control blood pressure and regulate the adaptive response to stress. In this animation, the biosynthetic pathways of adrenal steroid hormones, as well as congenital enzyme deficiencies in steroid hormone synthesis, will be reviewed. The biosynthesis of adrenal steroid hormones begins in the hypothalamic pituitary axis. Let's start by zooming in to this region. Neurosecretory cells are located within the hypothalamus. These cells secrete corticotropin-releasing hormone, or CRH. CRH is secreted into the hypothalamo-hypophyseal portal vessels. And is delivered to the anterior lobe of the pituitary gland. Let's zoom into the anterior pituitary gland. Here, pay attention to the corticotropic cells. CRH binds to corticotropic cells and stimulates the synthesis of adrenocorticotropic hormone, or ACTH. ACTH then travels through the circulation to the adrenal glands. The adrenal gland is divided into two distinct structures, the cortex and medulla. The adrenal cortex is surrounded by a capsule. The cortex is composed of three main tissue regions, the zona glomerulosa, zona fasciculata, and zona reticularis. Although the pathway to pregnenolone synthesis is the same within all zones, each zone is histologically and enzymatically distinct. The enzymes present within each zone determine which steroid hormones are synthesized. Let's zoom in on the outermost layer. The zona glomerulosa is the main site for production of mineralocorticoids, primarily aldosterone. All the adrenocortical hormones are derived mainly from cholesterol, absorbed directly from the circulation. Small amounts of cholesterol are also synthesized within the adrenocortical cells from acetate and LDL. Aldosterone production in the zona glomerulosa cells is regulated by various extracellular stimuli, such as angiotensin II and ACTH. These two stimuli lead to the activation of two distinct intracellular signaling pathways, an increase in cyclic AMP production and calcium mobilization. This results in the activation of desmolase, the enzyme catalyzing the conversion of cholesterol to pregnenolone. This conversion is the rate-limiting step of steroid hormone synthesis. 3-beta-hydroxysteroid dehydrogenase converts pregnenolone to progesterone. Next, 21-beta-hydroxylase converts progesterone into 11-deoxycorticosterone, or 11-DOC. Then, 11-beta-hydroxylase converts 11-deoxycorticosterone into corticosterone. Aldosterone synthase then converts corticosterone to aldosterone. We will now describe cortisol synthesis, which takes place in the zona fasciculata. Cortisol is synthesized from cholesterol in response to ACTH using cyclic AMP as a second messenger. The catalyzing enzyme is desmolase. This results in the formation of pregnenolone. 3-beta-hydroxysteroid dehydrogenase converts pregnenolone into progesterone, whereas 17-alpha-hydroxylase converts pregnenolone into 17-hydroxypregnenolone. There are two pathways that lead to the formation of 17-hydroxyprogesterone. One is from progesterone by way of 17-alpha-hydroxylase. The other is from 17-hydroxypregnenolone via 3-beta-hydroxysteroid dehydrogenase. (17-hydroxyprogesterone) is then converted by 21-beta-hydroxylase to 11-deoxycortisol. 11-deoxycortisol is converted by 11-beta-hydroxylase to cortisol. Once formed, cortisol enters the circulation. Now, let's take a closer look at the anterior pituitary. Here, cortisol inhibits the secretion of ACTH from corticotropic cells. Cortisol also has an inhibitory effect on CRH secretion from neurosecretory cells in the hypothalamus. In summary, cortisol's feedback inhibition occurs at both the pituitary and hypothalamus. Let's now zoom in on the zona reticularis to review the synthesis of androgens. As mentioned before, all adrenocortical hormones are derived from cholesterol, which is converted into pregnenolone via desmolase in response to ACTH using cyclic AMP as a second messenger. This is the rate-limiting step in all steroid hormone synthesis. Pregnenolone is converted by 17-alpha-hydroxylase into 17-hydroxypregnenolone, which is converted by 1720-lyase into dehydroepiandrosterone, or DHEA. Next, DHEA is converted by 3-beta-hydroxysteroid dehydrogenase into androstenedione. Meanwhile, pregnenolone is converted by way of 3-beta-hydroxysteroid dehydrogenase into progesterone, which is then converted by 17-alpha-hydroxylase into 17-hydroxyprogesterone. 17-hydroxyprogesterone is converted by way of 1720-lyase to androstenedione. Androstenedione exits the adrenal gland, undergoes conversion to testosterone, and is then converted by aromatase to estradiol. Now that we have discussed the normal process of biosynthesis of adrenal hormones, conditions related to enzyme deficiencies within these pathways will be reviewed. 21-beta-hydroxylase deficiency is the most common cause of congenital adrenal hyperplasia. It causes mineralocorticoid deficiency, hypotension, androgen excess, and female virilization. Neonates usually present with hyponatremia, hyperkalemia, and raised plasma renin. We will now illustrate changes within affected tissues as well as their pathways. Within the adrenal gland, let's take a closer look at the zona glomerulosa. The initial steps for adrenocortical hormone synthesis occur normally. However, a deficiency of 21-beta-hydroxylase prevents the conversion of progesterone into 11-deoxycorticosterone, which results in decreased production of aldosterone, the primary mineralocorticoid. The effect of aldosterone deficiency can be observed by zooming in on the kidney. Aldosterone deficiency leads to decreased sodium and water reabsorption, which results in hypovolemia. It also decreases urinary secretion of potassium, resulting in hyperkalemia. The macula densa cells are located in the distal tubule. They sense this decrease in sodium caused by aldosterone deficiency and subsequently activate juxtaglomerular cells on the afferent arterioles to release renin into the circulation. When renin is released into the blood, it converts angiotensinogen into angiotensin 1. Angiotensin 1 then circulates to the lungs. In the lungs, angiotensin-converting enzyme, or ACE, converts angiotensin 1 into angiotensin 2. Angiotensin 2 will have a compensatory effect to help increase levels of aldosterone by stimulating the adrenal cortex. We will now review the effects of 21-beta-hydroxylase deficiency within the zona fasciculata, the site of cortisol synthesis. Because 21-beta-hydroxylase is unavailable to produce cortisol from 17-hydroxyprogesterone, levels of 17-hydroxyprogesterone increase. Measurement of 17-hydroxyprogesterone is useful in the evaluation of patients suspected of 21-beta-hydroxylase deficiency. The resulting deficiency of cortisol causes an absence of negative feedback on the pituitary gland, thus yielding a stimulatory effect. This will lead to hypersecretion of ACTH, which enters the bloodstream and circulates to the adrenal gland. Long-term stimulation of the adrenal cortex by ACTH causes hyperplasia of adrenocortical cells. Within the zona reticularis, 21-beta-hydroxylase deficiency will cause shunting of steroid precursors to form more androgens. As explained earlier, there is an increase of 17-hydroxyprogesterone that, by way of 1720 lyase, converts to androstenedione. Androstenedione is then converted to androgens, including testosterone. The secretion of large quantities of androgens leads to sexual ambiguity and virilization of female neonates, as well as precocious puberty in male children. Let's now move on and review 11-beta-hydroxylase deficiency, the second most common cause of congenital adrenal hyperplasia. In this enzyme deficiency, there is mineralocorticoid excess, leading to salt retention and hypertension. There is also an excess of androgens. Let's go back to the adrenal gland and take a closer look at the zona glomerulosa. Again, the initial steps for adrenal cortical hormone synthesis occur normally. However, a deficiency of 11-beta-hydroxylase blocks the conversion of 11-deoxycorticosterone to corticosterone, and therefore leads to higher levels of 11-doc, which has a weak mineralocorticoid activity. 11-doc enters the bloodstream and is carried to the kidneys. Let's take a closer look at the nephron and zoom in on the collecting duct. Elevated levels of 11-doc will have the same effects on the collecting duct as aldosterone. Which are increasing the reabsorption of sodium and water and increasing the secretion of potassium. These actions lead to both hypertension and hypokalemia. Let's now review the effect of 11-beta-hydroxylase deficiency within the zona fasciculata. Here, the biosynthesis of cortisol proceeds normally until deficiency of 11-beta-hydroxylase blocks the formation of cortisol from 11-deoxycortisol and therefore leads to reduced serum levels of cortisol. Let's proceed to the anterior lobe of the pituitary gland and continue to visualize the effect of 11-beta-hydroxylase deficiency. A lack of cortisol in the blood at the hypophyseal artery will have a stimulatory effect on corticotropic cells due to a loss of negative feedback. This leads to hypersecretion of ACTH. Long-term stimulation of the adrenal cortex by ACTH causes hyperplasia of adrenal cortical cells. We will now continue to the zona reticularis and review the effect of 11-beta-hydroxylase deficiency there. Let's take a closer look. Within the zona reticularis, 11-beta-hydroxylase deficiency will cause a shunting of steroid precursors to form more androgens. Increased levels of pregnenolone are converted by way of 17-alpha-hydroxylase into 17-hydroxypregnenolone. 17-hydroxypregnenolone is converted by way of 17,20-lyase to DHEA. DHEA is then converted by way of 3-beta-hydroxysteroid dehydrogenase into androstenedione, which is converted to androgens, including testosterone. This secretion of large quantities of androgens is what leads to sexual ambiguity and virilization of female neonates, as well as precocious puberty in male children. Let's now proceed to 17-alpha-hydroxylase deficiency. 17-alpha-hydroxylase deficiency leads to an excess in mineralocorticoids and a deficiency in androgens. It's usually diagnosed at puberty with features of hypertension, hypokalemia, and hypogonadism. The effects of 17-alpha-hydroxylase deficiency on each zone of the adrenal gland will now be reviewed. Let's zoom in on the zona glomerulosa. The biosynthesis of pregnenolone proceeds normally until 17-alpha-hydroxylase is not available to convert pregnenolone into 17-hydroxypregnenolone. Therefore, this leads to an accumulation of pregnenolone, which is converted by 3-beta-hydroxysteroid dehydrogenase into large amounts of progesterone. 21-beta-hydroxylase converts progesterone into 11-deoxycorticosterone. 11-doc is a weak mineralocorticoid that leads to hypertension and a decrease in circulating angiotensin II, which has a second messenger effect in the conversion of corticosterone to aldosterone. 11-doc is converted by 11-beta-hydroxylase to corticosterone, which is normally converted by aldosterone synthase to aldosterone. However, due to a decrease in angiotensin II levels, aldosterone production will also be decreased. Finally, 11-doc circulates through the blood to the kidney. Let's zoom in on the kidney and focus on the collecting duct. Here, we see elevated levels of 11-doc with the same effect on the collecting duct as aldosterone, of increasing the reabsorption of sodium and water as well as increasing the secretion of potassium. Again, this will lead to both hypertension and hypokalemia. Let's now proceed to the zona fasciculata layer. Here we see the formation of pregnenolone and progesterone. 17-alpha-hydroxylase deficiency impairs the synthesis of cortisol. An insufficient amount of cortisol in the bloodstream will affect the pituitary gland. Decreased cortisol leads to loss of negative feedback within the anterior pituitary, resulting in hypersecretion of ACTH from pituitary corticotropic cells. ACTH enters the bloodstream. and circulates to the adrenal gland. Again, long-term stimulation of the adrenal cortex by ACTH causes hyperplasia of adrenocortical cells. Let's proceed to the zona reticularis. Once again, the synthesis of pregnenolone followed by progesterone proceeds normally. In 17-alpha hydroxylase deficiency, there will also be an inhibition of androgen synthesis. This leads to an absence of sex steroid production and subsequently hypogonadism.